two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 101. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Thanks, Swapnil. Everything well with you?
Yeah, it has been quite a busy period because it's winter. I guess we're seeing obviously more presentations in the hospital, and with the shortage of staff, I think the system is getting a bit overwhelmed. I'm not sure what's the experience with the staff shortages in India at the moment.
We are very busy in our hospital. We have a bit of shortage of staff as well. And as I mentioned last time, we have quite a few patients with non-COVID viral pneumonias over the last few weeks, which we are quite busy with as well.
Yeah, no, it has been the same pattern everywhere, I guess. And I think post-COVID, most of the health systems are dealing with staff burnout and staff shortages, which is also putting a lot of stress on each health system. Which is a quite interesting problem to deal with at the moment. So the topic the controversy that we decided to discuss today is around the use of tranexamic acid in intensive care unit. Now, the tranexamic acid is an antifibrinolytic agent which is used to prevent or treat life-threatening hemorrhage. Now, its use in intensive care has progressively increased over the period of time. And I guess there are several indications mentioned in most of the textbooks around bleeding trauma patient, traumatic brain injury, postpartum hemorrhage, GI bleed, epistaxis, hemoptysis, hereditary angioedema, bleeding diastasis, and also sometimes we use it when we use TEG or ROTEM guided resuscitation protocols. Now, the rationale why we use tranexamic acid in intensive care unit, it's a synthetic analog of lysine, which is amino acid, and it blocks the lysine binding sites on plasminogen, which in turn binds with fibrin. So thus, it prevents the activation of plasminogen to plasma, and the end result is tranexamic acid decreases the fibrinolysis and stabilizes the fibrin-rich clot. Now, this drug was invented back in 1960s by the Japanese scientist, and I guess since then there have been several indications which has been proven with robust evidence. And probably this is one of the drugs which has got a robust randomized controlled trial done with this agent. So I guess this is the drug probably which is most well studied in intensive care unit. Just from the pharmacology point of view, some of the side effects of tranexamic acid include headaches, seizures, visual disturbances, nausea, abdominal pain, some nasal decongestion, and I guess some allergic symptoms such as hypertensive reaction, anaphylaxis, and pruritus. And obviously, one thing that we always worry about when we use tranexamic acid is development of thrombus or DVTs in patients who receive tranexamic acid in high doses. And often the dose adjustments is recommended or required in the patients with renal failure. So today we are going to dive deeper into each indication for tranexamic acid in intensive care unit and what's the kind of evidence behind the use of tranexamic acid in those subset of patients. So let's start with the patients with trauma. And I guess this is probably the most well-studied and kind of well-recommended indication for use of tranexamic acid. So Dr. Checo, can you please walk us through the evidence behind the use of tranexamic acid in patients with trauma?
Yes, Swapnil. We have discussed this paper before as well, the CRASH-2 trial. So this randomized controlled trial specifically looked at trauma patients who were bleeding or at high risk of bleeding. And they conducted this study across a large number of hospitals, 274 hospitals across 40 countries within 8 hours of injury. The random assignments were to a tranexamic acid dose of 1 gram over 10 minutes, followed by 1 gram over 8 hours intravenously, or a matching placebo. And they looked at the all-cause in-hospital mortality within 4 weeks of injury. That's the primary outcome. And they found that the all-cause mortality within 6 weeks of injury was significantly lower with tranexamic acid compared to placebo, 14.5% in the tranexamic acid arm and 16% in the placebo arm, which was statistically significant. Besides, the risk of death due to bleeding was also significantly lower with tranexamic acid. So thus, this study very clearly showed that tranexamic acid safely reduced the risk of death in bleeding trauma patients. There were a few limitations, of course. The study was limited by a patient population with relatively low severity of injury, and penetrating trauma was also relatively low. One of the very strong predictors of ongoing bleed is, of course, penetrating trauma. And the majority of patients were from low-income countries with less developed trauma systems. So these were a few drawbacks of the study, but it showed in fairly robust fashion that in trauma patients, tranexamic acid is clinically useful in improving survival and reducing death due to bleeding. The second important trial is the STAMP trial, which was published in the year 2020. So this study assessed the efficacy and safety of pre-hospital administration of tranexamic acid among patients at risk of hemorrhage following severe trauma. This was a phase 3 multicenter, double-blind, placebo-controlled, randomized controlled trial. Patients included had pre-hospital hypotension with systolic blood pressure of less than 90 and were tachycardic with a heart rate of more than 110 per minute. And they arrived at the trauma center within 2 hours of injury. Dose of tranexamic acid used was 1 gram IV before arrival to the hospital or a placebo. And in the tranexamic acid arm, after they arrived to the hospital, they could get additional doses of tranexamic acid as well. The primary outcome was a 30-day all-cause mortality, which was not significantly different between the two groups in this particular study. On post-hoc analysis, they found that the 30-day mortality was lower in patients who received tranexamic acid within 1 hour of injury. Besides, the 30-day mortality was significantly lower among patients with severe shock with a systolic blood pressure of less than 70 millimeters of mercury. So, pre-specified dose response analysis revealed improved survival with tranexamic acid in patients who received a repeat dose with a total of 3 grams of tranexamic acid. So this study also, although the primary endpoint was not different between the two groups, on post-hoc analysis, there was definitely a trend towards improved survival in severe trauma. And they also noted that adverse events, including thrombotic complications, were not significantly different between the two groups. So these are the two studies which fairly convincingly tell us that in the trauma situation where your patient is bleeding or at high risk of significant bleed, tranexamic acid may improve survival and reduce the risk of death from ongoing bleed.
Thanks, Dr. Chakor. So I guess there is enough evidence to support now the use of tranexamic acid in the patient with polytrauma. And I guess that has been reflected across the world in trauma guidelines or even in the massive transfusion protocols that we practice, and that 1 gram tranexamic acid has to be given as soon as possible with the initial time of injury, and preferably within the first hour. But if not, then probably in first 3 hours. I guess when we talk about some of the drawbacks of CRASH 2 trial, as you mentioned, most of the patients were from low or middle income country. But I think if the trial showed a significant difference in these countries where the trauma system is not very evolved and has actually proven mortality benefit, I think that's even better outcome, because these systems where there's no well-developed trauma systems, then I guess even the use of this drug can actually make a lot of difference. So I think in a way it was quite a robust randomized control trial, which obviously has changed the practices around the globe. So I guess there's no doubt, I think now all the developed countries and developing countries both, I guess, practice the use of tranexamic acid. In fact, in defense now, we do give 2 gram tranexamic acid IV at the time of injury, because sometimes it's difficult to give the second dose as a bolus or over a period of 8 hours. So the current recommendation in the TCCC guidelines is to give 2 gram tranexamic acid at the time of injury as soon as possible. So let's move on to the second cohort of patients, which is also quite interesting, the traumatic brain injury subset. So can you please walk us through the evidence behind the use of tranexamic acid in this cohort of patients?
Yeah, that's the CRASH 3 trial, which gives us good information. The CRASH-3 trial assessed the effect of tranexamic acid in patients with traumatic brain injury. This randomized controlled trial was across 175 hospitals in 29 countries, and it included adult patients with TBI within 3 hours of injury with a GCS of 12 or less, or any intracranial bleeding on CT were also included in the study. A total of 12,737 patients were randomly allocated to receive tranexamic acid or a matching placebo. Tranexamic acid was in a loading dose of 1 gram over 10 minutes, followed by an infusion of 1 gram over 8 hours. The TBI-related death in hospital within 28 days of injury in patients treated within the first 3 hours of injury was the primary outcome. But this outcome, the primary outcome, was not significantly different between the tranexamic acid and the placebo groups. However, they did pre-specified subgroup analysis as well when they excluded patients with a GCS of 3 or bilateral unreactive pupils. Again, the 28-day mortality was similar. However, TBI-related death was significantly lower with tranexamic acid in mild to moderate TBI, defined as GCS between 9 and 15. However, there was no significant mortality difference with severe TBI, defined as GCS of 3 to 8. So it suggested that mild to moderate TBI patients may benefit, although overall, there was no difference between the tranexamic acid and the placebo groups. So this study shows that perhaps we should investigate the use of tranexamic acid a little further among patients with less severe TBI between GCS of 9 to 15, because this was only based on a subgroup analysis. So that's the main trial that has addressed the question of the usefulness of tranexamic acid in patients with traumatic injury. There we do not have a clear-cut answer, but whatever trend that we have suggests that mild TBI, early use may be beneficial.
Yeah, that's correct. I guess, and I think that's still the very important evidence available on this topic, because TBI mortality or the overall outcomes have been quite concerning over the period of time. And I guess clearly with mild to moderate TBI, at least tranexamic acid, and probably the way the mechanism it works, it probably stops the rebleeding or it reduces the subsequent bleeding after the initial insult. So if it's administered within that first golden hour, then obviously it helps to reduce the mortality. And I guess the uptake of this evidence has been quite slow, I must say, across different hospitals. And I guess some people are using it quite aggressively in TBIs, while some people are still not very keen to adopt this evidence because it has not shown overall difference in the mortality. But yeah, I think that's something the interesting space to watch. So moving on to the third indication, that is the obstetric and gynecology patients with postpartum hemorrhage. So Dr. Chaco, what's again the evidence behind the use of tranexamic acid in pregnant patients who are presenting with postpartum hemorrhage?
Yeah, postpartum hemorrhage is a major complication post-delivery, post-cesarean delivery, as well as normal vaginal delivery. And even today, there is a significant mortality associated with it. The main problem with pregnancy and childbirth is early activation of the fibrinolytic system soon after childbirth, wherein the TPA levels increase sharply, likely due to tissue damage during childbirth. And normalization of the fibrinolytic system takes time. It might take as many as 3 to 4 days. So on the basis of the results, the favorable results in bleeding trauma patients, the efficacy of tranexamic acid was evaluated in primary postpartum hemorrhage refractory to the conventional uterotonic agents in the woman trial. So this particular trial aimed to evaluate the effects of early administration of tranexamic acid on death, hysterectomy, and other important clinical outcomes in patients with primary postpartum hemorrhage. This multicentric randomized controlled trial was conducted across 21 countries, 193 hospitals. Patients with a clinical diagnosis of PPH after vaginal delivery or cesarean were included. The dose of tranexamic acid was 1 gram intravenously. A second dose of 1 gram could be administered for continuous bleeding after 30 minutes or for recurrent bleeding within 24 hours of the first dose. In the control group, they received a matching placebo. 20,060 women were included in the study. Death due to continued bleeding was significantly lower in the tranexamic acid group, 1.5% versus 1.9%. So that was significantly lower with the use of tranexamic acid. And the effect on mortality was most profound in patients who received tranexamic acid within 3 hours of childbirth. So this study again shows that if you're administering tranexamic acid, it's better to give it early than wait. The requirement for hysterectomy was not different between the two groups. The composite endpoint of all-cause mortality or hysterectomy was also similar. Adverse events, like many other studies previously, again, was not higher with tranexamic acid, particularly thrombotic complications, which you expect with a antifibrinolytic drug. It didn't happen in this trial either. So the woman trial suggests that tranexamic acid may be beneficial in reducing PPH-related death. The study was limited by a change in the primary endpoint. Initially, the endpoint was hysterectomy and a composite of hysterectomy and all-cause mortality. But then they realized during the study that the decision to perform hysterectomy was usually made at the time of randomization. So they changed the primary endpoint. That was one of the drawbacks, of course, but regardless of that, it very clearly showed a reduction in mortality due to bleeding in PPH.
A very large, robust, randomized controlled trial, which was conducted across many countries. And again, hats off to the investigator for conducting such a difficult trial with a large number of patients. And again, gave a very clear signal in terms of mortality benefit with use of tranexamic acid in patients with PPH. And I guess now has become the part of the practice. And I guess that's been the quite interesting pattern with trauma, tibia, and postpartum hemorrhage, because all these bleedings are acute and all these patients are at high risk of developing that fibrinolytic cascade. I think the tranexamic acid definitely has got a role in those acute bleedings. Now, moving on to some of the subset of patients who technically don't have that kind of problem of acute bleeding, that is cardiothoracic surgical patients. So I guess what's the kind of evidence behind the use of tranexamic acid in patients undergoing cardiothoracic surgery?
There is a randomized controlled trial that has asked this question, whether tranexamic acid would help in patients who undergo coronary artery surgery who are at high risk for perioperative complications. That's the ATTACK-HAS tranexamic acid trial, in which tranexamic acid was administered after the induction of anesthesia in a dose of 100 milligrams per kilogram intravenously, compared with placebo in patients who were at high risk for both perioperative complications after coronary artery bypass surgery. And they used a fairly high dose, 100 milligrams per kilogram. And this dose was actually halved during the course of the study as seizures were reported with tranexamic acid and considered to be dose related. So they cut down the dose during the course of the study. They looked at the primary composite outcome, which was death and thrombotic complications in the 30-day postoperative period. The thrombotic complications evaluated included myocardial infarction, stroke, pulmonary embolism, or bowel ischemia. The primary outcome was the composite, as I mentioned, of death or thrombotic complications was similar in the two groups, 16.7 with tranexamic acid and 18.1 with placebo. The difference was not statistically significant, but tranexamic acid administration was associated with a significant reduction in the requirement for blood product transfusion during hospitalization. And they also noted that major hemorrhage or pericardial tamponade requiring re-exploration was significantly lower with tranexamic acid use. So although the primary composite outcome was not different, these studies suggested that tranexamic acid may reduce the requirement for blood products, and it might reduce major hemorrhage and pericardial tamponade requiring re-exploration. As I mentioned, they observed seizures with tranexamic acid use. That's why they cut down the dose halfway through. So here again, there is a distinctive signal, at least, that in patients who are at high risk of bleeding after coronary artery bypass surgery, prophylactic tranexamic acid administered soon after induction of anesthesia may be helpful.
Thanks, Dr. Chekko. So I guess it's partly understandable because obviously exposure to bypass triggers the fibrinolytic process and the coagulation cascade. And I think that's where the tranexamic acid, or previously we used to use epsilon aminocaproic acid, ECA, they all kind of shown reduced bleeding. Obviously, there were issues with the ATTACK-HAS trial in terms of the design and how the the dose was changed halfway through. And again, that's another interesting point to mention about the tranexamic acid is at the standard dose of 1 gram IV loading dose followed by 1 gram infusion over 8 hours. At that dose, all the trials so far, including woman crash 2 or crash 3, did not show increased risk of thromboembolism. While obviously with a higher dose than to up to 100 milligram per kilogram, then obviously Atticus trial showed a side effect, and especially with the seizure, which is quite a concerning side effect. So I guess people just need to be mindful about the dose and the usage. So I guess the use of tranexamic acid in the cardiac surgery is, again, not probably the routine use. Some centers do use it, or some patients who are at risk of bleeding, they will get TXA, but I guess it's not, again, a very routine practice. Now, moving on to the last subset, which is the GI bleeding patient. So, Dr. Jacko, can you please walk us through what's the evidence behind the use of TXA in patients presenting with upper GI bleed?
Upper GI bleed, of course, is of great concern because it carries a reasonably high mortality of close to 10%. And lower GI bleeding also has its own share of mortality of up to 3%. So it will be good to use a medication that would reduce bleeding and perhaps reduce mortality as well. Now, that's the reason why the HALT-IT randomized controlled trial was conducted, given the background of a substantial mortality reduction observed in meta-analysis of patients who received tranexamic acid for upper GI bleed. So this multicentric HALT-IT trial was conducted across 164 hospitals in 15 countries. These patients had a significant upper or lower GI bleed. Tranexamic acid was administered in a loading dose of 1 gram over 10 minutes, followed by an infusion of 3 grams over 24 hours, while the control group received a matching placebo. Death due to bleeding within 5 days of randomization, which is the primary outcome, was similar between the two groups. It was 4% in both the groups. So that's the primary outcome, death within 5 days. But even more importantly, there was deep concern regarding the incidence of venous thromboembolic events, including deep vein thrombosis and pulmonary embolism, which was higher tranexamic acid use, 0.8% versus 0.4%, which was statistically significant. Although arterial thromboembolic events, including myocardial infarction and stroke, were similar. So this randomized controlled trial, the HALT-IT trial, not only showed that it does not result in reduced mortality due to acute hemorrhage in the first 5 days, it might also lead to an increased incidence of venous thromboembolic events. Arterial thromboembolic events were not significantly different. So that's a situation in which you perhaps would not consider the use of tranexamic acid.
Thanks, Dr. Jacko. So I guess this trial has, again, clearly gave us an answer that TXA is not indicated in patients with GI bleed. Now, a lot of people might kind of ask why TXA worked in trauma patient, TBI, or postpartum hemorrhage patients, and to some extent in cardiothoracic surgical patients, but not in this cohort of patients. And the rationale for that is probably the patients who are presenting with GI bleed, they usually have underlying other comorbidities like liver cirrhosis. And obviously that affects the coagulation pathway in a different manner. The second rationale for this is the GI bleed patients usually present quite late to the hospital because we usually see them when after 12 to 24 hours of the initial bleed has happened. So obviously they bleed, then they kind of compensate for a while, then they become unstable, and then we kind of intervene. So we don't see them in first 1 hour or that golden hour of where the tranexamic acid is actually effective. And I guess the third important rationale why probably TXA did not work in this cohort of patients is because they usually have hypofibrinolytic phenotype. And that's probably why the TXA did not work, and in fact cause increased risk of thrombosis. And I think that's kind of explains why this kind of cohort of patient did not respond similarly to other cohort of patients to TXA. So I guess that phenotype or personalized medicine or identifying the right subset of patients in which the TXA will be suitable is quite important. And I think that's why the blanket statement that any patient who is bleeding needs TXA, that's not the truth. And I think that's why we need to be very careful and cautious about the use of TXA in certain cohorts of patients only, which includes trauma, TBI, and obviously postpartum hemorrhage. So, Dr. Chacko, that's the kind of my takeaway from this evidence. What's your takeaway and what's your current practice?
Yes, we tend to use tranexamic acids definitely in postpartum hemorrhages, which these days is not very common, thankfully. And I think it is an important indication. It certainly works, and it's been shown to work in this situation. Bleeding trauma patients, perhaps, yes. We don't use it routinely, but in patients who are at high risk with ongoing bleed, of course, we would strongly consider it. Traumatic pain injury, we don't use currently. Perhaps we should catch up and consider it strongly, at least in situations wherein they have milder traumatic brain injury, as has been shown in the CRASH 3 trial. One of the other indications for the use of tranexamic acid is primary intracerebral hemorrhage, in which it has been studied, but the results are equivocal. They looked at the functional status at 90 days by the modified Rankin score, not different significantly between placebo versus tranexamic acid. They found a lower 7-day mortality with tranexamic acid, which did not translate to 90-day mortality. So again, it's questionable, perhaps not a reasonable indication to consider tranexamic acid in primary intracerebral hemorrhage.
Yeah, I guess, and that makes again sense because all the studies that have been done so far with TXA has clearly indicated that when there is a clear mechanism for activation of fibrinolytic pathway, such as trauma, then obviously it works quite well. However, the mechanism for primary intracerebral bleed is not the endothelial injury to start with. Obviously, there's probably enough reason why there's a fibrinolytic pathway is not hyperactivated. So coming back to that kind of tailor your approach to the patients or the indications, understand the pathophysiology, and obviously use the drug cautiously, knowing what side effects you might get if you use it in excess. So I think that's probably the good takeaway message to finish on. So thanks, Dr. Chacko, for your time. We'll be back in, again, weeks or fortnights time with another episode or another controversy. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. Till we meet next time, goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.